Okay, let's keep going. We're going to shift gears here and talk about the other side of the excitatory inhibitory coin, which is GABA, and its utility in treating both mood disorders and particularly anxiety disorders. So we'll talk about benzodiazepines in this section. So you remember that GABA is the other side of the coin to glutamate. So the primary job of GABA is to be an inhibitory neurotransmitter. It is actually synthesized from glutamic acid. And there are two different types of receptors for GABA. So there's GABA A and GABA B. And the GABA A receptors are those fast-acting ionotropic channels that allow for negatively charged ions like chloride flow in. So this is really kind of the brake pedal of the brain. And if you remember from our previous talk, there are lots of different sites where drugs can bind to the GABA receptors. There's, of course, the places where the endogenous GABA neurotransmitter binds, but then there's all these different things such as for ethanol, alcohol, of course, the different benzodiazepines, Z drugs, barbiturates, and all these things contribute to whether or not this receptor is going to open or close. And typically they're going to contribute to it opening. They're going to be positive allosteric modulators. So when that channel opens up, these negatively charged chloride ions can flow in, which is going to make it less likely to fire. Now, this is primarily how benzodiazepines work. And these GABA interneurons play an important role in regulating the activity of other neurons. So we saw that in the talk about ketamine, about how there's a GABA interneuron that hangs out right next to a glutamatergic neuron. And when the GABA interneuron is firing, it inhibits the glutamatergic neuron from firing. So these kind of GABA interneurons, they serve as sort of telling other neurons to hold off when they are activated, when they're firing. Allosteric modulation, just as a reminder here, is so in order for an allosteric modulator to work, you have to have the endogenous ligand, in this case GABA, and if we're combining it with an allosteric modulator, so a positive allosteric modulator is going to cause that receptor to respond even more robustly. In this case, open up and allow those chloride ions to flow in. It's going to allow that to be even more amplified. So a positive allosteric modulator without the endogenous ligand. So if in some kind of theoretical world you had a benzodiazepine but no GABA, wouldn't do anything because you've got to have both together in order for there to be an action. So the most of the all the benzodiazepines, not most, all of them are positive allosteric modulators. That's probably why they have this PAM at the end of their name. So lorazepam, clonazepam, alprazolam. That doesn't make any sense, but most of them seems like there's exceptions to every rules. But they are all positive allosteric modulators. So you can just think about how they work with endogenous GABA to cause that to open up. Now, here's where things get a little bit weird. It was recently discovered in the last 10 years or so that a drug called brexanolone, which is essentially a analog of allopregnanolone, had an effect in helping postpartum depression quite rapidly when given in an IV infusion over the course of about 2.5 days. And the exact mechanism of this is not totally clear. It does seem to be a positive allosteric modulator, but it's not a benzodiazepine. So it's a little bit quirky, and I wish I had better explanation for how this worked. But it's one of these things where, the exact mechanism of action isn't totally clear, but this is the result. So, let's sort of acknowledging that a number of things in psychopharmacology are a little bit of a black box. We don't always know how they work, but it appears that brexanolone is definitely a rapidly acting antidepressant for postpartum depression, and it's been FDA approved since 2019. And you can see these separations here. So this green being the placebo group. So everyone getting this significant drop, but definitely the brexanolone group dropping more significantly and staying lower throughout the duration of the treatment period. Now, the downside to this is that you have to do it in an inpatient hospital because they need to be monitored and it needs to be given IV through continuous infusion. And it's very expensive. It's about $35,000 for the drug alone. And then you tack on the cost of the hospitalization. So, you could easily be looking at, $65,000, $75,000 for one course of treatment. So, in the interest of making this more pragmatic, the drug zuranolone was developed. So, this is a rapidly acting antidepressant that got an FDA approval fairly recently for postpartum depression. So, this is essentially an oral version of brexanolone. Now, the thing that they were really hoping for was that this would also work for regular major depression, not postpartum, but just plain old major depression. And you can see that in the postpartum depression, there was this separation between the two groups, and this gave it FDA approval with the goal being that somebody gets better by about 2 weeks in. But for major depression, did not see that separation. So the drug was given approval for postpartum depression, but not for major depression. It's still quite expensive. It's about $15,000 for a 2-week course of this. But there is insurance coverage for it sometimes. But this is a useful tool in our armamentarium for treatment of postpartum depression. Now let's talk more about when people think about GABA, they usually think about benzodiazepines. So I want to spend some time talking about anxiety, and then we'll talk about benzodiazepines, and we'll also talk about other ways that we can deal with anxiety that are not benzodiazepines. So this is some practical tips about how to work with anxiety and benzodiazepines. Before we can treat anxiety, we got to identify it. And most of the time, people will come to us either or with a physical experience of anxiety. So, if you work in an emergency room, you might see a lot of this. You might see people coming in saying, "Gosh, I'm having a heart attack because I can't breathe, and my heart is pounding, and I feel dizzy." Or you may have people coming in with more of a cognitive emotional experience of anxiety where they can't stop themselves from thinking about the same thing over and over again. They're really tense. They feel really uncomfortable. They're worried about something. Often these things too are overlapped on each other. And this makes a lot of sense when we think about where does anxiety actually arise in the body, physically in the body, somatically. It's really the autonomic nervous system. And the autonomic nervous system, if you remember from your anatomy, is divided into sympathetic and parasympathetic branches. So sympathetic is probably better known, and this is our fight or flight system. And when we look at all the things that happen when we go into sympathetic activity, it's all things that would be helpful for survival if we were being chased by a saber-toothed tiger. We want our heart to beat fast. We want to be sweating because we want to be able to dissipate heat very quickly. Maybe we want to evacuate our bladder because we don't want to be spending energy holding on to that while we're trying to run away from a tiger. And then the corollary to this is the parasympathetic nervous system. So all the things that we want to be available when we are relaxed and digesting are on the parasympathetic side of things. So when I talk to patients about anxiety and about non-medication ways of addressing anxiety, I often talk about this idea of like a saber-toothed tiger. Like if I was running away from a saber-toothed tiger, there's no way that I would be taking slow, deep, deliberate breaths as I do when I'm doing a grounding exercise when I have anxiety. So we can kind of hack our body, use our body as a sort of a hack for our brain. I realize that's sort of an artificial separation, but the brain really uses the body as a danger detector. So if our heart rate gets up really fast and our brain can't figure out why, it says, wait a second, is something wrong down there? Are we running away from something? Are we in danger? So we can work that system backwards too. So if we're taking slow, deep breaths, we're expanding the thoracic cavity, we're stimulating the vagus nerve, which is the primary message conduit back up to the brain of the parasympathetic nervous system, and we start to calm down that sort of anxiety response. So there is some real science to this. It's not just, quote, psychological. We're really kind of working with the autonomic nervous system. Now, if I was to describe anxiety disorders in one word, I think the word would be avoidance. And here's why. So, anxiety is going to occur. It's sort of part of being human, of course. And when that happens, a lot of times what occurs is that, we feel something off in our body. Like, many people with anxiety, I find, are very interoceptively sensitive. So they're very aware of the interior of their body and they're prone to misinterpreting it. And so let's just say something feels off, And our brain starts making a story. It says, oh God, what if I faint? I'm out here in public. What if I faint? And so we start to feel anxious. And then eventually the anxiety kind of peaks and subsides. That's the natural course of anxiety, right? Is that we go up, 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 and then it breaks and we come down and we feel better. It's a good thing, right? But then our brain starts saying, uh-oh, well, what if that happens again? That would be a bad thing, right? And so we start to look at the situation that was happening when that anxiety signal arose. And maybe we start to avoid that thing. So we were out in public when it happened. So now we think, well, gosh, maybe I should just stay home. Then it won't happen. Of course, if it doesn't happen, then that avoidance is reinforced. So we go, whew, I'm glad that didn't happen. And the downside to this is that sooner or later we're going to have to go out, but that's going to induce anxiety because we're now avoiding that thing that was once anxiety provoking. So we don't end up going, we don't get anxiety, and then that avoidance is then reinforced further. And this is what kind of can spin out into what we call agoraphobia, where people just don't go out in public, for example. And it's gotten a lot easier now because we have avoidance collaborators called grocery delivery and Grubhub and all those things that we use so we don't have to go out. And so you can see how this can sort of escalate. I think we saw this definitely with, say, the pandemic. There was already obviously anxiety around public health, but then, you have kids that aren't going to school, for example, and they're learning from home. And I don't know about you, but high school for me was sort of like 4 years of exposure therapy for social anxiety. So I was a lot more comfortable in my skin by my senior year than I was in my freshman year, probably because every time I had to go to school, I had a little bit of exposure therapy and I couldn't avoid the thing that made me anxious. So take all those kids out of school for, a year or so, and it really impairs this learning process. So, anxiety, I use this a lot with patients. I'll explain, so you ever had one of those smoke detectors in your house that goes off every time you make dinner? Well, that's kind of the area of your brain that is firing, but it's going off when there's no actual real danger. But the reason why it feels so real is because it's the same part of your brain that goes off when there's actually a real danger. It's just misfiring. So if we were to think about this, again, I use this metaphor with patients all the time. I say, this part of your brain is like TSA. Nobody gets onto that plane without going through the metal detector, without going through security. And what's the job of security is most of the time, everything coming through that space is benign. So, that we can think of, the people standing guard at the security station. They are, the eyes and ears. They are that switch, that sort of channel that everyone has to go through. And the amygdala is primed and ready for a danger, right? So it's looking, and it's going back and forth with the hippocampus. So that part of the brain that says, hey, is this person a danger? Is this person a danger? Is this the person we're looking for? And most of the time, things go through, there's no alarm that goes off. So everything coming up through the brain has to come up uh, through the base of the brain, past airport security. All the stuff coming in the cranial nerves, everything has to come through the thalamus and the amygdala and airport security. Okay, so the job of the airport security is to detect when there actually is a danger, right? So again, same situation, right? But now we actually have a real danger, right? This is how it should go off, is that when there's an actual real danger, the amygdala says, hey, something is wrong here. The hippocampus says, that's the guy we're looking for. And we set off the alarm in the form of the sympathetic nervous system. However, for many of our patients who experience anxiety, particularly panic attacks, that security is going off all the time for no good reason. Now, in the DSM, we often talk about anxiety disorders as if they're kind of like a model, they're these clearly definable things. And the reality is it's a lot more of kind of a bunch of blobs that have some overlap here. So this is probably the most common anxiety presentation is generalized anxiety, GAD. But panic sometimes goes along with that. Agoraphobia often goes along with panic. Social phobia often accompanies generalized anxiety. OCD is a little bit, not technically an anxiety disorder, but there can often be a lot of anxiety that goes with OCD. People may have a trauma history. They may overuse alcohol in order to try and address that anxiety. There can be a lot of anxiety in people that have personality styles that don't tolerate distress very well. And then, of course, depression and anxiety go along hand in hand. Most people if they have anxiety long enough, often will become depressed. And, anxiety is really the common cold of psychiatry. Now, because anxiety has this very physical component to it, we have to figure out, is there actually a physical component here? And the problem is, the more we dig around in that, the more we're probably likely to make the patient anxious. And so a lot of times patients will come to us in psychiatry because their primary care person can't find anything wrong with them. In that case, they've often had a medical workup, which makes our job easier. But if they haven't had any kind of medical workup, we need to at least look for possible medical complications, at least the common ones. I would not suggest going on a deep dive of very rare medical complications because remember, we are not house here. And the reality is, if we go back to, Occam's razor, common problems are common. Uncommon problems are unlikely to show up. And if we spend too much time focusing on this, we're probably going to freak the patient out. And so we need to look for specific symptom clusters. Like I'm thinking about a patient I had some years ago who came to me with fairly new onset of anxiety, but a lot of fatigue as well. He was a bus driver and no real history of anxiety, but he said, especially when he would do anything like trying to go upstairs, he would feel really anxious and short of breath. And I looked at him, I thought, gosh, you are really pale. And I thought, let's just get some labs on this guy. Turns out his hematocrit was like, or not his hematocrit, his hemoglobin was like 6. He had a GI bleed that he was unaware of. And once he got some blood transfused in him and we got that GI bleed worked out, he didn't have anxiety anymore. So, there are situations where somebody's going to have anxiety that does have a medical component to it. Obviously, if somebody is presenting into your ER with an acute MI, they're going to be anxious. That's appropriate. Sometimes things like AFib can present as anxiety because somebody's having palpitations, things just don't feel right. Sort of easily worked out with an EKG. Hyperthyroidism can often cause anxiety. And these sort of acute things, obviously somebody getting a pneumothorax is going to feel obviously anxious, and that would be appropriate. But you would see other symptoms of poor respiration, poor gas exchange. Vertigo definitely can cause sort of an anxiety type presentation. When people have had a concussion, they can have anxiety type symptoms. Anaphylaxis is an obvious one. It's going to be a very obvious onset. And then a lot of substances, including medications, can cause anxiety as well. Cannabis probably being a very common one, but probably one of the most common ones being caffeine. Honestly, it's kind of remarkable how many of my patients will sometimes tell me that they're, consuming 800 to 1,000 milligrams of caffeine per day, and they're telling me about their anxiety and their insomnia. And so in that case, it's not a job to prescribe, it's a job to help them figure out how to reduce their caffeine load. And a lot of us, we don't realize how much caffeine we're ingesting. So, I would encourage you to take a look at this and, add up your numbers for the day of how much caffeine that you take in a day. Not that students would ever do that, right? So, when we're making this call, we got to look at the constellation of symptoms. We don't look at a single symptom. Obviously, we have an older patient who has a history of heart disease, has a sudden onset of anxiety and chest pain. That's an MI until we prove otherwise, right? But these more nebulous cases sometimes are a little tricky to work up. Now, I want to go back in history a little bit as a means of introducing how we got to benzodiazepines, because that's a really important part of this conversation. So back in the early part of the 20th century, we really had two kind of groups of psychiatric conditions. We had, what we might think of as serious mental illness, and we had what was then called psychoneurosis, which would be your sort of GAD and major depression kind of presentations, right? And all these things got treated with tranquilizers. We really didn't have antidepressant medications at that time. And there were sort of two groups of tranquilizers. We had what were known as minor tranquilizers, which were initially the barbiturates and later the benzodiazepines. And we had the major tranquilizers, which would be the dopamine blocking drugs, which we'll talk about in that section of class. But the GABA modulators, so these began with the barbiturates. So the barbiturates came out, the turn of the 19th into the 20th century, and these are your phenobarbital, pentobarbital, chloral hydrate, and these lock on to the GABA A receptors, and they don't let go. And that makes them irreversible, which also makes them very dangerous in overdose. We think that Marilyn Monroe probably died in part due to an overdose of chloral hydrate and pentobarbital. So we don't really use these so much in psychiatry anymore, because the other thing that makes them more dangerous is combining them with alcohol. But they are used in neurology. So my dog, for example, has seizures and he is on phenobarbital. So very useful in that. It's made a huge difference for him. And here's an interesting drug. I don't know if any of you watched Mad Men, but there's a reference to this drug, Milltown. And this was a really common drug in the 1950s and 1960s. So it's sort of between barbiturates and benzodiazepines. It's actually a carbamate. So we don't, the way it works is not fully understood, but it has this kind of generally sedating effect. And it was enormously popular. This is a direct to doctor drug ad from the 1960s here, because 500 million prescriptions of this stuff were were written during those times, and there was only about 100 million people in the US at the time. It's really not around anymore, but the drug carciprodol, which is Soma, is marketed as a muscle relaxant, is essentially carciprodol is the prodrug for meprovamate. So it's kind of still around, but nowhere near as popular as it was back in the 1950s and 1960s. So then come along the benzodiazepines. So benzodiazepines come in the early 1960s. Chlordiazepoxide, which is Librium, you're probably familiar with that from alcohol detoxification, was the first one to come along. Um, Sometimes they're called hypnotics, sometimes they're called anxiolytics. Basically, it's the same drug. If you're taking it at bedtime for sleep, it's a hypnotic. If you're taking it during the day for anxiety, it's an anxiolytic. Same. Very useful drugs. Would be hard to imagine a desert island without one, but really valuable for acute anxiety, for alcohol withdrawal. Obviously, we use them still in sort of addressing seizures, particularly like status epilepticus. And they're all very similar when they actually get to the target. So the GABA receptor is their common target, and they all do the same thing when they get there. But where they differ is their kinetics. So how quickly they're absorbed, how quickly they get into the brain, and then how long they stick around for, and if they have active metabolites. So we talked about this a while back, that lipophilicity, that ability to cross the blood-brain barrier, is one of the things that makes a benzodiazepine work quickly or slowly. And some of the most sort of fast-acting benzodiazepines are the ones that are lipophilic. So that's your alprazolam, diazepam, temazepam, all rapidly acting. And then you can see they vary in how long they stick around. So they all will kind of peak in 1 to 2 hours, but you're going to see a significant duration of how long they last. And it's worth pointing out that a couple of them, lorazepam and oxazepam, are not really processed through the liver. And so those are helpful to know about if you have a patient who has hepatic issues. And there's a lot of challenges with benzodiazepines. Obviously you don't want to be on a lot of benzodiazepines and driving. They may have some issues around memory impairment, especially at higher doses. Some real concerns about combining them with opioids. That's where I think benzos have gotten a lot of scrutiny as part of the opioid epidemic, overdose epidemic. And then sort of common precautions around how do we use these with older people? We need to be really cautious because of the risk around falls. And then these questions around diversion, tolerance, and misuse. One of the big things that sort of started giving people pause around benzodiazepines is this question around long-term chronic use, not taking this, on occasion when you go on a flight or something like that, but taking this, a couple times a day for many years. Does that expose somebody to more risk for developing dementia down the road? Or do we see an increase in anxiety as somebody begins to develop dementia? Now, there's been some more sophisticated ways of trying to kind of tease this out, like looking at people that had not taken a benzo for several years before they were diagnosed with dementia, to see if we could kind of separate out that group of people that get more anxious as they begin to lose cognitive ability. But there does appear to be somewhat of a signal there that long-term chronic use of benzodiazepines is really not good for your cognitive health. Now, a lot of these benzodiazepines are coming from primary care, which I know the majority of the people watching this content are coming from. And I totally get why this happens, is because, when you have 7 minutes to work with somebody, you need things that are effective and reliable. Benzos are that, and so as you are becoming more of a psychiatry provider, I really, want to encourage us to think about other ways of dealing with anxiety besides benzodiazepines. The other group I want to really be to kind of call out here is those patients that are co-prescribed benzodiazepines with opioids. I know there's been a lot of efforts on the part of pharmacy and safety guidelines really discouraging this co-prescribing, but often when somebody does have a significant overdose event from an opioid, there can frequently be a benzodiazepine on board, and both of those contribute to respiratory suppression. There are some drug interactions. Some of the benzodiazepines are processed through 3A4, so your kind of classic 3A4 inhibitors can reduce the metabolism of these particular drugs here. But really, the big concern right here is this combination of opioids plus benzodiazepines, and of course now naloxone should be co-prescribed with uh, all ongoing opioid medications, I think, and now that we have it available as an over-the-counter medication, it's still not quite cheap. I think it's, about $40 for a 2-pack like that. So, that might be a deterrent for some patients, but there are certainly means of getting this to patients at a lower cost. But it's this combination of opioids and benzodiazepines that is concerning for increasing overdose risk. And so, in the medical community, particularly in the NP community, I see a lot of back and forth about benzodiazepines, and I'm seeing a lot of people kind of leaning towards the right here and really almost becoming phobic of prescribing benzodiazepines. When I first trained in 2005, we gave a lot of benzos away. And we didn't give them away; we prescribed them, but we would typically give people, say, a month's worth of a lorazepam or something like that as we were starting them on an SSRI for their anxiety. And I would educate patients that the plan was to take them off the benzodiazepine once the SSRI began to work, but many times it was difficult to stop them because people said, well, that one really works and I want to stay on it. And we'd end up continuing to prescribe them. What that led to is some people taking chronic benzodiazepines, which is probably not ideal. But now we've kind of swung to the opposite side where we have this sort of messaging that's happening. I saw this on a social media post, this kind of punitive approach towards patients that are asking about benzodiazepines, assuming that everyone who might ask for one is somehow going to abuse them, which I think is really inappropriate to make that assumption. Now, while I know probably everyone watching this has cases that they can talk about where they've seen misuse of benzodiazepines, I want to also point out that there are many people who don't. And this idea that we should just reflexively take everyone off of benzodiazepines, I think, is really also short-sighted, because that's what we did with opioids. And look how that turned out. We gave those away freely for years, and then we pulled the rug out from people, and guess what? The black market stepped in. And so I think this we need to do better. But the best way we can do this is probably by thinking about how we can avoid prescribing them. And one of the easiest ways to avoid prescribing them is to not give them to people as a way of aborting panic attacks. And here's why it doesn't work. It has to do with pharmacokinetics. So again, going back to the cycle here, right? Somebody has this spontaneous feeling of discomfort and they go, oh no, I'm feeling really, doesn't feel good. I'm going to take one of those Valium. So what will happen is, remember, even if they didn't take the Valium, that anxiety is going to go up and eventually it's going to peak and it's going to come down. But what ends up happening is that as it's going up, people take a medication, and then the medication sits in their stomach for a few minutes, and the anxiety keeps going up and eventually comes down. And while it's going down, the medication started to dissolve and it's starting to get to the brain. And so their anxiety is already coming down when this benzo arrives on site, right? So it's the anxiety was going to go away anyways. But what happens is we teach the patient that the thing that made the anxiety go away was the drug. And what that creates is wanting to have this medication available, because what if that happens again? And then, of course, if they keep taking it, maybe they don't have that anxiety, or you see patients that will sort of carry around, medication bottle they've had for years with some, almost crumbling benzodiazepine tablet inside, because they have this fear that this might happen again at some point in the future. But if we do this enough times, we teach patients that what ended the anxiety attack was not time, but the drug. And that just doesn't line up with the kinetics. So what we end up doing is really kind of reinforcing this behavior, and it becomes a kind of avoidance. And if, by the way, if you're ever going to have a patient that's going to do exposure therapy for anxiety disorders, you do not want to give them a benzodiazepine going in, because it's going to actually blunt the anxiety response, which you don't want in an exposure therapy model, because if you blunt the exposure anxiety response, you're going to blunt the desensitization to that anxiety stimulus. And if somebody keeps taking it just on a regular basis, they're going to get physiologically dependent. Okay, so what this becomes is kind of almost like a talisman against feeling anxiety down the road, and that tends to encourage people to keep taking the medication, or even to increase the dose. And what this does is it really creates a wedge with our therapeutic relationships. So if somebody finds that they have to take more than what we've prescribed them, and then they ask for it early, then we're saying, why are you asking for this early? Are you misusing this? Are you giving this to somebody else? It creates a problem in the therapeutic relationship. And then, of course, if we stop it suddenly and they've been taking it for a while, they can go into withdrawal. And the withdrawal from benzodiazepines is very similar from the withdrawal from alcohol. So if you are going to use a benzodiazepine, I suggest thinking about it like prednisone. We would never give somebody a bottle of prednisone and just say, here, just take this, keep taking it. We would give them a dose, and then we'd give them an off-ramp. We'd give them a taper. And I want to encourage you to think about using benzodiazepines in much the same way. So if you are going to use a benzodiazepine for a period of time while you begin a SSRI, for example, go ahead and specifically lay out the taper schedule. So maybe in this case, this person's going to take a little bit during the day to keep the anxiety under control, and a little more at night to get some sleep. And then we're going to start reducing it down. And so there's a clear expectation set here. And we're not also sending conflicting messages like saying we're going to taper you off and then putting 4 refills on it or something like that. And so if you were going to use a benzo, using it in this kind of scheduled, prescribed way, I think is better than just saying, here, just take this whenever you feel anxious. And if somebody's been on a benzodiazepine for a long period of time, and for whatever reason you need to stop it, maybe they're an older person and they're having falls or something like that, what we're going to do is something that is referred to as the Ashton method. So the Ashton method, I'll give you the link in a second, but the idea here is you combine all the benzodiazepines, because this is often somebody who's taking 2 or 3 different benzodiazepines, and we consolidate them into, like, similar to like morphine equivalents. There are benzodiazepine equivalents, and these use diazepam as their common drug. So we would consolidate them into diazepam. And the nice thing about diazepam is it's long acting, has active metabolites. And so you would convert it into that and then go down very slowly. That might be 25% a month. That might be even 10% a month. So yeah, it might take you a year to get somebody off of chronic benzodiazepines. That's okay. And while you're doing it, you're going to need to address the other things that were being addressed with benzodiazepine. So if they're having sleep problems, they might need trazodone or melatonin. If they're having anxiety, they might need an SSRI. Or you can even take this more conservative approach called hyperbolic tapering. And so what hyperbolic tapering is working from is the idea of this hyperbolic curve here is what it refers to, that the occupancy of the target is not necessarily proportional to the dose of the drug. So let's take a look at this here. So if you look at this green box here, so you see it, they use citalopram as an example. So 60 milligrams of citalopram will occupy the serotonin transporter by about 88%. But interestingly, when we go down to half of that, so 30 milligrams, we're only just marginally reducing the occupancy. We're somewhere about between 80 and 85%. Even if we go down to 10% to 1/6 of that, we're still occupying it by 70%. So you can see what happens is like as we get down to like 2.3 milligrams, we're still occupying it by 40%. So what you can see here is we might need to do a proportionally smaller and smaller and smaller dose. So I like to joke that my parents are English and nobody ever takes the last cookie. They will break the last cookie in half, and then somebody will come along and they'll break that half in half. And so we get into these smaller and smaller portions of the last cookie, right? So if something, say you're reducing somebody off 20 milligrams of diazepam, we might start at 20 milligrams, reduce it by 10%, go to 18 milligrams a day, right? And then we're going to go 1.8 of that. So now we're at 16.2 milligrams. And then we're at 10% of that, which is 1.46 milligrams. So you can see what we're getting smaller and smaller, but we're flattening out the curve as we get to the end. And usually with benzodiazepine tapers, the first part is okay. Once you get the patient to buy in that this is what we're going to do, first part's okay. It's the last part that you have to go really slow. And often what you need is a liquid formulation of one of these medications so that you can make these tiny, tiny reductions over time. This is the Ashton Manual, freely available online from the UK. Now, this question of should we have contracts for controlled substances? There was a time when I was doing this with everyone in the interest of sort of equity, trying to treat everyone exactly the same. But mostly, and I've gone to a more kind of targeted approach when I think that, somebody or if a patient has any kind of history of misuse of medication. And really the point of this is not to be punitive, but to be clear. So the idea here is that we spell out what is an on-time refill. We tell patients when can they get their medication refilled and through what channels? How do they contact us to do that? Because a lot of times patients don't know what an on-time refill is. And so, I don't know, they ask for it 10 days in advance. And we say, that's too early. And we say, well, what's on time? And then we won't tell them. Like, well, why don't we just tell them? Like, 5 days before you're supposed to run out is a reasonable amount of time. Or if it's a mail order pharmacy, 10 days. But just being clear and giving that to your patients so that we're on the same page. I think that kind of clarity and communication goes a long way to preventing these kind of potential ruptures in your treatment relationship with your patient. The other thing you want to get in the habit of using is the prescription drug monitoring database, which in California is called Cures. And this allows you to look up all the controlled substances that have been prescribed to that person over a period of time. I think it's 1 to 2 years. And we've got to give people other skills. This is a pharmacology class, so I'm not going to get too much into this, but really, we got to check with ourselves and make sure that we're not thinking like we got to prescribe for every single thing. There are plenty of other ways to deal with anxiety that don't involve medication, psychotherapy, obviously things, lifestyle changes, reducing caffeine, reducing alcohol, reducing cannabis can all be things that might help somebody reduce their anxiety. And so I want to be clear, I am not anti-benzo. There was a time in my early career when I gave a lot of benzo prescriptions out. Now I still use them, but I'm much more discerning about how I use them. So, I have a number of patients who have a real severe fear of flying. I'm happy with them taking a benzodiazepine before they get on a plane. I'm really cautious to tell them don't go to the bar as well. Don't have a drink on the plane because that combination can be, a lot. But, or somebody's going to an MRI or they've just gone through a serious period of grief or crisis. Certainly in the emergency room, they're really invaluable medications, psychiatric emergency room. So, I do think there's a place for them. I'm cautious with using them chronically with patients with anxiety disorders. Probably the only exception to that is if like nothing else is working, I might go to a chronic benzo, but I tend to avoid them. Just a little note on Z drugs. So Z drugs they work on a neighboring receptor to where the benzodiazepines work. You can see on that alpha 1 receptor there of the GABA receptor is where the Z drugs work. These were marketed as being non-benzo sleep medications. So this is your Ambien, Zolpidem type medications. work very similarly. They have less of that anxiolytic effect, but they have more of the sedating effect, which is their subtle difference from benzodiazepine. The problem with them is these sort of parasomnias that people would get with them. So, sometimes people would cook in their sleep, or God forbid they drive, or they have sex in their sleep and they don't really remember it. So again, this is a class of meds that I used to prescribe a lot of, and now I'm more cautious with. And so, you can make up your own mind about how you want to relate to these. But they do have some risk of these parasomnias. Again, if I'm going to use them, probably in short-term use, for somebody who's maybe doing night shifts periodically and needs something to help them sleep. But I want to try and avoid using these every night. Okay, so in the last section, we'll take a break here, and then the last section we'll come back to non-GABA, non-benzodiazepine ways of dealing with anxiety. Thanks for your attention.